graduated from Howard University College of Medicine 51 years ago. And one of the reasons why I decided to stick around was because of this problem, the opioid epidemic. Opioids, that's what we're talking about. Opiates are naturally occurring. Opioids are synthetics like buprenorphine, heroin, fentanyl, and methadone. Those are all synthetics. And these are some of the generic names and brand names. So we can see that the opioid epidemic really started well before this slide here. And you can see how the blue areas, how the opioid fentanyl epidemic advanced across the country. And it appears in the Northeast for the most part, and then spread west. Heretofore, we've heard the opioid epidemic was primarily a rural epidemic, missing the fact that African Americans were impacted for years. In 2019, 2020, African Americans actually surpassed the per capita rate of overdose deaths. And we can see with fentanyl, this dramatic increase. And who's impacted? Black men, off the chart. And the reason is because fentanyl hit the urban areas with the switch from heroin to fentanyl and impacted African Americans in urban areas. So African American males are now dying at the fastest rate, way off the chart. And then a few years ago, another additive, not an opiate, but an animal tranquilizer was added to the supply. And you can see this uptick with xylazine that's now spread all across the country. So these synthetics are what's killing people. This is all of the states, but when you look at the District of Columbia, look at the marked disparity between white and black overdoses. There's no other state in the country that with that marked disparity. So that should tell you something. So this is Dr. Nora Volkow. She's been the director of NIDA for over 20 years with some definitions of addiction. We know that there's a genetic component to susceptibility, but also environmental factors, particularly stress. And we know that there are other chronic diseases like diabetes and hypertension with far less than 50% efficacy rate. With opioid treatment, with the medications we have, we should be able to achieve better than 50% decrease in deaths, but we have not. We now define opioids as a chronic disease. Before it was considered a moral problem, especially when I was in medical school. And addiction was not considered to be a disease until about 8 years ago. It was officially recognized as a medical specialty. We talk about abuse, which implies impaired roles, legal problems, continued use despite of those problems, but not quite reaching the criteria for dependence, which is, again, the person develops a tolerance. You get withdrawal symptoms when you don't have that particular substance and require larger amounts in order to achieve the same level of feeling. This is a picture of the brain. The red area is the prefrontal cortex, and that's where we call the area of executive function. Yes, no, tells you when to stop, when to go. And that's the very most important part of this. And these are just depictions of the many nerve cells in the brain, really showing how dopamine and serotonin, which cross those pathways and send the signals down the channels in the brain. So again, this is a cross section of the brain, and it really shows that's the cycle of addiction, binge intoxication, withdrawal, and then preoccupation and anticipation. So you go through this cycle with any addiction. They didn't have these pictures when I was in medical school. These are pictures from what are called PET scan or positron emission tomography. On the left-hand side, we can see a normal brain activity. In the middle, a brain on cocaine, and on the right side, a brain in recovery. So now we know that there are actually changes, physiologic changes in the brain. We no longer ascribe this to simply being a moral phase. And this is the developing brain from the age of 5 to 20. We know that in males, the brain generally is not fully developed until the age of 26, females 23. That's why women are smarter than men. And we can see in this slide that the most susceptible time is the teenage years because the brain is not fully developed. So we use this diagram, we call it the pair of ACEs, adverse community environments at the bottom, and adverse childhood experiences at the top. So obviously, if the roots are rotten, slavery, Jim Crow, all of those particular things that impact us in the communities, violence in the community. Currently, I would also include colonialism and gentrification. The tree is going to have problems. And so that's how we get the adverse childhood experiences, maternal depression, emotional and sexual abuse, substance abuse, et cetera. These are all ways or forms of addiction, including gambling, smoking, even drinking coffee. When we talk about addiction, if you are a jazz fan, you probably are a little older, you might probably remember Billie Holiday, had a very traumatic childhood and subsequently suffered from addiction to alcohol and drugs. But then it was treated as a criminal problem. And her most famous song was what? Strange Fruit. And what are the words? Blood on the leaves and blood at the roots. So that's the tree. We know Frederick Douglass as the great emancipator, but we also did not know that generally that he was a leader of the abstinence or temperance movement. So that he believed that temperance and the issues with slavery were joined at the hip. You cannot stagger to freedom. So when we look at our history, we've really suffered in silence due to shame. The faith community has rejected people, medical providers, until even now reject or don't accept this as a medical problem. Family and community ostracism, government apathy, inequitable insurance and pharmaceutical payments, and an incentivized prison industrial complex. So we're caught in this maze. There's a community disconnect. So this is Dr. Gabor Mate, a Canadian physician, who talked about toxic stress and the fact that in medical school, most physicians are not taught how to deal with stress. But this quote over here really talks about the Lakota Indians and the fact that if you're sick, we are sick. The community is sick. It's not your individual problem. It's a community problem, which is a different way of approaching medicine in our community. And he recently wrote the book, The Myth of Normal. So we have a number of barriers, particularly in the African-American community. We're only 5.7% of physicians, 4% of psychologists, 2% of psychiatrists. So when we look at that history and superimpose it on the District of Columbia, we can see this diagram. In 2014, there were only 83 opioid deaths. As of the end of 2023, there are 518, and that's not the final number. And you can see that they're disproportionately found in the ages 40 and above, representing 70%. But we also have an increase in young people as well. This is the xylazine impact. So as of last year, we had 15 deaths related to xylazine and fentanyl. 98% of our deaths, or 96 to 98% of our deaths are related to fentanyl, not drugs from the doctor's office or the hospital. So this slide actually shows this dramatic increase in young people under 19. We went from in 2022, 3 to 2023, 12. So something is happening there. We can also see that the overdose deaths are disproportionately on the east side of the city, wards 5, 6, 7, and 8. And this actually shows how other diseases are parallel with that. So these are the overdose deaths. These are the murders. Those are AIDS and hepatitis C, all on the east side. They're parallel diseases. My office is here. That's my parking lot. That's the McDonald's next to my office. We also have to talk about housing or homelessness, because again, we'll see that there's a disproportionate death rate in the homeless. I'm sure if you read the newspapers, you're very familiar with the homeless encampments downtown and how they were evicted. 20 got housed. This was about a year ago, 50 unhoused. So you're really just scattering the problem. You're not solving the problem. Again, this shows that incarceration was treatment for the most part. And this is the cycle of despair again. And it can start any place. It might start with the loss of a job, might start with criminal activity, mental illness, homelessness. So wherever you start, the result is the same. And after prison, there's more punishment because you can't get a job, you can't get housing. So we need to reverse engineer all that you've seen. So we call this law enforcement assisted diversion. Rather than drug-free zones, you need somebody to take people to treatment. That would be the humane way. This is a profile of my patients back in 2015. You can see the average age then was 52, 2/3 male, average years incarcerated 10, greater than 50% required mental health medication, but 90% have a diagnosable mental health problem, generally anxiety and depression. 10 to 12% already HIV positive, 60 to 65% hepatitis C positive, 90% smoke, and the life expectancy is cut short 20 to 25 years. So my average patient age now is 60. You're all familiar with Narcan, the overdose reversal drugs. Comes in 4 milligrams, 8 milligrams. There's a newer drug out now called nalmefene that works faster and lasts longer. This is Dr. Marie Neiswander and Vincent Dole. They were the first to use methadone to treat opioid use disorder back in the 1960s. They were pioneers. Many people don't know this young lady. She's now 97. She was the first in around 1965, 66 to treat a pregnant woman to term using methadone. She just retired, I think last year. She's amazing. She's amazing. She's my hero. Oh, she's also a Howard University graduate, 1955. She was National Medical Association Practitioner of the Year in 2020. And she's also the antidote to stigma. You have to go online and Google her, Melissa Freeman, and you'll see a number of videos. So we now use 3 medications. I talked about methadone. Buprenorphine came out about 22 years ago, which is so-called partial agonist, and naltrexone, which is an antagonist. So methadone is still considered the gold standard. It can only be prescribed in clinics at 2,000 clinics across the country. Buprenorphine can be prescribed in any physician's office who has a DEA number, but many physicians do not treat. Naltrexone came out about 7 years ago, and to my understanding is not as effective as the other two. So methadone and buprenorphine, we know, actually decrease overdose deaths by at least 50% when used appropriately. So this is a person potentially on heroin, and this is the first hit, and you can see that this person is in the high range. And these are some smaller hits that get that person in the so-called straight range. And then finally, the person gets too much and overdoses. So we attenuate that using these medications, buprenorphine and methadone, so that instead of having this, we have this impact. So the person gets methadone there, and then tries to override it with heroin or fentanyl, and the impact is attenuated because of the medication, because it ties up those receptor sites. So this is the rationale for opioid replacement therapy: to stabilize the brain, to prevent withdrawal and craving, and to extinguish impulsive behaviors. This is several doses of buprenorphine, starting with 0 to 2 milligrams, 16 milligrams, 32 milligrams. And you can see as the doses get higher, more of the receptor sites in the brain are taken up. I simply want to show here that if you're in a community where less than 70% fentanyl is more optimistic, as opposed to our community on the far right, where we're near 99% very pessimistic in terms of being able to get on top of the problem. So this was a symposium at the American Society of Addiction Medicine 2 years ago. Dr. Helena Hansen in the middle really for at least 25 years has talked about how buprenorphine was racially marketed. So African Americans by design did not get access to this office-based medication. This shows that only 2.7% of prescriptions written for buprenorphine, the office-based medicine, was prescribed to African Americans. So this is Dr. Edwin C, who also showed that in the face of these very potent opioids, that we actually need higher doses of buprenorphine and buprenorphine and methadone in order to overcome those. And you can see on this map a marked disparity in dosing for buprenorphine. Here in California, they can dose up to 48 milligrams, but in Nevada, Tennessee, Indiana, Pennsylvania, only 16 milligrams. So what happens if you need a higher dose and by regulation you can't get it? That means that you're going to suffer, and this is by regulation. So we're trying to change that. So we found this out here in Washington, D.C. through patients in my office working with the Howard University College of Pharmacy, and wrote 2 papers in 2017, 2019, showing that higher doses of buprenorphine were more effective, especially above 24 milligrams. It was not accepted, and today we're still battling that. I participated in a SAMHSA FDA NIDA meeting in December, and this was one of the slides that was presented that actually showed that 24 milligrams, you can see a marked change after 180 days in efficacy. So how do we reverse this? This was on CNN. Jake Tapper interviewing the mayor of Los Angeles, Karen Bass, showing the relationship to housing, substance abuse, and mental health. 90% of patients could not participate or get housing because of costs. And these are all things associated with homelessness, particularly physical, mental health problems, and addiction. So it costs $125 million to just in emergency services in LA. But by housing people, they were able to actually reduce those costs to $55 million. So it's actually cheaper to have people housed. You can find them, you can really work with them and give them everything that they need. So Karen Bass says it's inhumane to allow people to die on the streets. And housing is not enough. We need healthcare, social service support, and treatment works. This is a young lady, 27 years old, mother of 4, Southeast Washington, fell asleep on the bed with some fentanyl pills. The 3-year-old got some of them. She woke up, the 3-year-old was not breathing and died. So the long and the short of this, she's now on trial for murder. That means that the mother goes to jail, and the 3 surviving children, the government is going to have to take care of. So who was the health insurer at that time? She's in DC, so we know she probably had DC Medicaid. This is one of my patients who was on 32 milligrams of buprenorphine that I talked about before, switched insurance companies that cut his dose to 24 milligrams, and he overdosed, but he survived. Washington Post happened to be on top of it. This ended up on the front page. That same day, we were able to get his dose increased back to 32 milligrams. The gentleman sitting over there, if I might say, overdosed 8 years ago under my building. He was resuscitated, and this is following that incident. He's now there, he's written a book, and he's fathered 2 sons. And this is my longest patient on buprenorphine. I got him in 2005. He was 57. He's now, he'll be 77 next week. And he had diabetes, but didn't know it, hypertension. We also had hepatitis C. Took 5 times to refer him because the insurance company didn't want to pay for it. He got 3 months of Harvani, and he's cured of hepatitis C. This was done at CBS Studios in New York. So we have elephants in our community. This really shows that only 1 out of 5 people who need these medications actually get it. And when you talk about African Americans, it's 1 out of 10. So we should replicate what Karen Bass did in Los Angeles. We should get the homeless off the street because we know housing is medicine. And this simply shows a combination of undomiciled plus unknown from our chief medical examiner's report. If you add them together, you can see here it was about 2% 10 years ago. Now about 30% of the overdose deaths are in the homeless. So we need the same thing that gallery place need in my parking lot. It can't be just one place. It has to be the whole city. This is Dr. William Lawson, and he's actually showing how trauma has impacted the African American community for 400 years. This was actually a slide that I showed back in 2018 at the Office of Minority Health. In order to solve this problem, we need the entire community, and it has to be structured in what we call a community-centric treatment where everybody has a role. This is from the American Medical Association. It's a new concept, and it's called systems thinking. Instead of having the cycle of despair, we want the cycle of repair. Post-incarceration, post-hospitalization, self-referral, homeless shelters, that we need advocacy in the community. We need medical support and medications. We need individual and community education, housing, food, clothing. So in this new concept of community-centric care, we bring in everybody. So we call these integrative services, screening for AIDS, hepatitis C, treatment for diabetes, and regular medical problems, as well as mental health services. And we can see just in this diagram, any chronic disease that you can name, if the person has no mental health problem or substance abuse problem, the costs are about a quarter. They quadruple with any disease if you have both on the red bars on the right side, whether it's asthma, congestive heart failure, coronary artery disease, diabetes, or hypertension, the costs go up because people don't take their medicine, they don't see the doctor. So this is Dr. Benny Prim in New York, 40 years ago, developed this model. So this is not new. He did this and also brought in social services, job training, all kinds of services well before computers. So this was the diagram when I was invited back to Howard University to the Department of Behavioral Health and Psychiatry. We put together this screening profile, and it looks real complicated, but it's not. So you do social screening, mental health screening, integrated medical care, medical outcomes, social outcomes, and the cost savings are tremendous. This shows how now with telehealth, we can integrate these services so patients can be in one place, the doctor or provider of those services someplace else, and we can even wrap in the faith community in this diagram. This is Regina LaBelle. She's had multiple titles, including acting drug czar, now is the director of the Addiction Public Policy Program at Georgetown. We have the public policy right here in Washington, D.C. We have Mr. Roach Brown. So we have media access. This is the Leadership Council for Healthy Communities, which is a faith-based group. And we actually have put in a number of proposals and actually have a returning citizens grant with the Department of Behavioral Health. That's Howard University College of Pharmacy. That's Howard University School of Community Health and Family Medicine. This was a lecture at Georgetown. Ms. Sullivan Robinson there is our grant writer. We also have the crews depicted right here. And this is what we call a community partnership to advance science with service. Thank you. We need your help.
I would like to, first of all, on behalf of our club, we have a tradition where we plant a tree in your honor. And so this is to commemorate your talk here today. And we are going to plant a tree right here in the Tidal Basin at one of the beautiful cherry blossoms that everyone comes out to see.